I think with that, we're at 1 minute past the hour. We'll get started. Just make sure we make the most of our time together. For those of you I haven't met, my name is Caroline Knutson. I am the COO and one of the co-founders of the After Cancer. I'm thrilled to have this discussion today with two wonderful guests. A bit of background on the After Cancer. The After Cancer is a digital platform for cancer survivorship support. So we partner with organizations to be an extension of what they're already doing or to help do that in the virtual space when it comes to survivorship support of their patients and users. So without further ado, I would love to get us started with our two wonderful guests. The topic today is on survivorship care plans. We host these sessions, expert insight sessions, once a month. The idea being to bring some of those really critical topics in survivorship support to the fore and have a great space for discussing them, especially with experts in the field. So without further ado, Dr. Bailey-Dorton and Elle, if you two can introduce yourselves and we'll get started.
Sure. Thank you, Caroline. So my name is Dr. Chasse Bailey-Dorton. I am the medical director and one of the co-founders for the After Cancer. My background is initially in primary care, also trained in integrative medicine fellowship. And for the last 13 years, I've been doing or developing integrative oncology programs and survivorship programs in large cancer centers. Probably my better background is as a 24-year breast cancer survivor, which gives me a whole new insight to a lot of these things. So looking forward to our discussion today. Elle?
Hi, my name is Elle Zilar, and I am an oncology nurse navigator, and I specialize in survivorship. I have a background before I was in oncology care. I was an emergency room nurse. Really liked that field. I always wanted to help people who are really facing crisis. I wanted to be there with them. So I feel like with oncology care, that's a natural progression. I also have certifications in holistic nursing and nurse coaching, as well as working now with our survivor population. So I'm looking forward to talking with you all today. I hope you have lots of questions, and I guess we can get started.
Great. So today our topic is, as we mentioned, on survivorship care plans. And I kind of want to start out with, I think, four main intents of the survivorship care plans. And we could talk about those four, and then we could talk a little bit afterward about what works, maybe what's missing, and how Elle's been able to implement or change or make this successful in her practice. I think, one of the tenets of the survivorship care plan was providing this treatment summary to the patients at the end of treatment, which is great because, it's given their diagnosis, their stage, what treatment they received. It also lists their oncology team, which is great for a patient to have. If they move, they change locations, they have that information with them. So I think they're informed. However, I have seen at some cancer centers, it's just kind of a box that's checked. The form is completed. It's maybe handed to the patient and they don't really understand everything that's in there. So on the one hand, I think it's a great summary. On the other hand, I'm not sure our patients quite understand the power of what to do with that. Elle, would you agree with that?
I completely agree. Our patients are so used to being handed packets of papers. It's just another packet of paper unless we bring some life to it. So I think that's really important. And if I can, I'll just kind of dive into what I do in my survivorship appointments. Our clinic, ideally, we hear from the NCCN, COC, these kinds of organizations that they should be looking at survivorship appointments immediately after the first course of treatment. That doesn't always happen for us either, but we do see them as quickly as possible. And when I bring them in, we've conditioned our patients to when they come into appointments, we lead the conversation, and they're so used to that. But this is an opportunity to kind of change that up so that they can lead the conversation. The very first thing I say to my patients when they walk in the door is, hey, I've read your chart. I do know what your diagnosis is. I know how we've treated you. I know some of the side effects, but what I don't know is what this experience has been like for you. And so I tell them, I'd like to take the first 20 or 30 minutes, if you don't mind, for you to tell me. A lot of times this conversation, or when I tell them this, it's just met with a pause. They're just not sure what to do with that. And a lot of times I'll just say, well, let's just start at the beginning. How did you know you have cancer? And that leads into a really, really robust conversation. When they start to begin to tell their story, I can identify several things. One, what's been lost, what remains, what gives them hope, what they're afraid of, where they are struggling, and what strengths that they may no longer recognize in themselves. And I think those are really important points to listen for. Generally, when they're done talking to me about their story, I will tell them, hey, I see these places that you've been really strong. I recognize these strengths in you and I admire that. I will move on to say, but I'm also hearing that there's some needs that that we haven't met. So I encourage them to start talking about that. One of the things I think is really important if we're going to do survivorship appointments is to know what our resources are and to know which resources our patients need. They don't need every resource in our basket. They need the ones that are going to help them. I find that some of the things that are not talked about, things that they won't bring up that I have to bring up, are things like depression, and also sexual health is a big one. Almost none of my patients have ever talked about sexual health, yet each one of them is affected by cancer and their sexual health. And this is a tough topic to bring up, but if we bring it up, it lets them know that this is not only common, we expect some of these side effects and we have resources to help them with those. And that opens up even more conversation.
What you're describing is kind of, we have this treatment summary that we're giving them in a packet, but you're also doing a treatment summary of their experience of what they've been through. It's kind of the same way that I do integrative oncology appointments. That first appointment at the beginning of treatment is, I've read your chart. I know what's going on. Let me hear from you, your story, what's going on, how you've been diagnosed. So you're kind of giving them their experience as a treatment summary, which I think is a great working besides just the data. So I think that treatment summary is important. The second aspect of a survivorship care plan intent is a communication with our primary care docs. And, coming from a primary care background, I'm not sure how sure we're making that effective for our primary care docs. I'm not sure how many primary care docs actually get the packet or get the survivorship care plan. I think there's still a question if they get that summary, who's responsible for what? Who's responsible for these screening? Who's responsible for these things? So I don't know how you guys are communicating your survivorship care plan with the primary care docs.
I'm going to address that. For us, we are pretty fortunate in that our survivorship care plans are within our EMR, and I can send them right out through the EMR. But I also always send a note to the primary care physician saying, this is what we're going to continue to do, but these are the things that we'd like you to do. Obviously, if it's been 10 years in surveillance and we're discharging, I let them know, hey, here's where we're discharging them. We're going to return them to your care. Included is a list of the things that they're going to need, on an ongoing basis. So
I think that's awesome, especially, with those long-term survivors, we know how to do that. I think it's that first year often at the end of treatment where it gets confusing about who's doing what. And, our patients have gone through this situation where they've seen that treatment team every 6 weeks. They got the navigator, they have the infusion team, they have the clinic nurse to kind of feeling like they're dropping off a cliff at the end of it. So I think it's great to make that communication with the primary care doc.
yeah.
The other aspect of a survivorship care plan is potential long-term side effects.
Yes.
And I think sometimes that can be a little frightening for a patient to read that because they've just gone through treatment while they might already have some side effects. So how are you dealing with the long-term side effects that are listed in the survivorship care plan?
I always talk about them with our patients, and I say I really let them know these don't happen for everybody, but they could happen for you. And by you realizing or talking about them right now, you'll recognize the signs and symptoms if they start. And the sooner that you get back to us, or the sooner you let us know what's going on, the faster we can get right on top of that because we have things to help. And I think that gives them some ease. It also kind of empowers them. If I know that I might get lymphedema and I start to have some of those symptoms, I know that I need to get on top of that. And of course, they always have our phone numbers so they can call us. And they do commonly down the road. I'll hear from somebody and say, hey, remember when you told me this? This is happening for me. It gives me a chance to get in there and navigate that for them a little bit.
That's awesome. And then the fourth bucket I see with these plans is, the follow-up care and what screening is needed down the road. I think sometimes that's another area that can get confusing between the oncologists and the primary care docs. I've seen occasionally see a patient in the midst of treatment talk to the oncologist, say, "Hey, I'm out of my hypertension medicine. Can you just send me in a refill?" And then that runs out, and then it's lost in transition. So just there's some overlap there. So how do you handle that? Who's doing what, the oncologist or who's ordering the screening for follow-up care?
Right. We have it, we have it pretty well lined out what the screening will be. Anything that has to do with cancer, until we discharge them from the clinic, our physicians still order. Occasionally they'll jump in and they'll fill like a medication if they're patients in an emergency situation, but then we get a message about that and we get them reconnected with their primary immediately. We have ways to just message their primary and say, "Hey, this patient needs an appointment. How fast can you get them in?" I always set myself a reminder to make sure they've gotten that appointment. If they haven't, I pick up the telephone and
That's
say,
awesome.
"Hey, they need in."
That's awesome. So, so I think the survivorship care plan can increase communication between our different parties, which is fantastic with the patient, with the primary care, and if they're traveling out of town, they have this document with them. I think it increases the patient knowledge of what treatment they had and what they need to look forward to or watch for in the future. But there's one issue, I think I often tell patients that as stressful as diagnosis and treatment was, I think the end of treatment is harder. That's where they feel like they're falling off the cliff with coming from the close oncology follow-up to, well, I didn't know I had this in the first place. Is it going to come back? Now I have these side effects. Will I know if the cancer comes back and can I do anything to keep it from coming back? So I'm not sure we're addressing that distress that happens at the end of treatment. So how are you guys? It sounds like you're doing that in your survivorship visit, but I'm not sure everybody has the ability to have an integrative oncology like I do or what you're doing.
You're right. Not everybody does.
I wanted to just
And 100% people feel lost after their treatment ends, and some they miss that supportive, those support people. So I do think that the care plan is very important because it just, point by point lays out what they're going to need for surveillance, what kind of tests. And when they have that fear of recurrence, those are things we talk about too. But I tell them one of the best ways to combat that is to get your
talking to me?
screenings, because if we catch things.
Oh, she's on mute.
Sorry about that. Don't know what happened. But anyway, if they know what's coming next, what scans are coming next, we talk about, recurrence that's caught early. We actually have things that we can do. And so I think that empowers them too, just by knowing that, if I get this scan every year, if something changes, I'll know. And definitely we very much let them know that if they start to experience something that doesn't seem normal, call me.
Yeah.
We'll get you back in.
I think the other population that has needs that's not addressed in this is our patients who are going to be on long-term care. Our stage 4 patients who are actually thriving and doing well, but they're going to be on treatment for the rest of their life. They have a lot of needs that aren't met through this either. Have y'all addressed that in any way?
Yeah, 100%. I completely agree with you. In fact, when we have our meetings for the Committee on Cancer, that's my barrier that I always point out. We aren't doing enough for stage 4 patients, because you're right, Dr. Bailey, they're going to live for many years, a lot of them. They also need that support. Maybe they need that support more, because they need to know what the transitions are and how they approach those things. So we don't have that completely ironed out. That is something we're addressing.
Yeah. So, those were kind of the points I had to start with. I'd kind of like to open it up to questions or hear input from somebody else on the call, how they're handling this, what they've found works, what doesn't work, and how they can help us all work better.
We've had loads that have come through the chat, actually. So I might just kind of start in order and then we can open it up to the room. Would love some people to come off mic too and ask as well. So first is more of a statement from Jackie that says, I do a synopsis at the top of the treatment summary specifically for the PCP responsibility after year 5. So not sure if you guys have any thoughts on that or comments.
That sounds great.
It does.
Yeah. Do you have a way to know that the primary care doc is receiving that information?
Jackie, if you feel
Sorry,
comfortable,
I'm
feel free
gonna
to
come
put.
off. Yeah, I'm coming off mic. So, yes, basically we have the Epic, we have our Epic platform, and so I'll send it out electronically to them. Of course, it'll get faxed if they're not part of the Epic program, but initially they were just getting that full treatment summary. And now this was before I came into this position, but they were overwhelmed by the amount of information that was there and didn't really understand what it was, and they hated it. And so it for the, at least for the breast cancer patients, there was like a little CP blurb that was put up there. So now I've actually formulated that for several of our other cancer sites. So like your prostate, your colon, et cetera, just to have like what their responsibility is after year 5 in the blurb. So that way they have a snapshot. And yes, they do get it. And apparently they like it a lot better than just having the whole treatment summary and not knowing what to do with it.
That's awesome. So you've delineated that they take over it after year 5. It makes me think about I used to get reports from a patient to be in the emergency room. You know, you get like 30 sheets of paper and you could never figure out what had happened with them. So I'm glad you've streamlined that.
We've tried, at least. We'll see.
Jackie, I have a question. When you talk about the little blurb, we also have Epic, but is that little note that you have a chance to type out while
Yeah,
you're
there's actually, so it's on the full treatment summary, but we have like a box. I keep forming it like I'm talking to a camera. we have a we have a box that's at the top of the treatment summary, and it's like maybe 4 to 5 little excerpts of, follow up, H&P every year, per PCP recommendation based off of their comorbidities, and then what to monitor for if there's any lab work, long term, if like TSHs or not necessary. And we'll tell them, there's no reason to check a long term lab for, say, CEA or anything like that, or routine cancer screenings, long-term effects, what's a good recommendation for neuropathy if there's a long-term. So I have like little short 5-sentence thing that goes to them.
That's really good. That's perfect. That's what they need, because I've heard that as well. Providers say that is just too much information to go through. And when we're used to seeing the form, it seems easy to us. But like Dr. Bailey said, when you're getting this form and you don't know where to look, it's terrible. So I love that you're putting in the little blurb. That's very helpful.
Yeah, awesome work.
Yeah.
All right, our next question comes from Alyssa. So her question is, what do you see as the role of advocacy organizations in survivorship care planning to help or augment the role of the clinician? And then her follow-up is, or what do you wish they would do? So what do you see and what do you wish they would do?
Well, I think part of it is just messaging that these survivorship care plans exist, that they're there for the benefit of the patient, and they know what they're supposed to do with it or what information it contains and how it can help them.
Yeah, and I think, what the care plan does is it gives you the evidence-based research. They tell us exactly what the science says. And so that is very empowering for our providers, our general practitioners, as well as our patients, because they know exactly. So when we talk about advocacy groups, yes, I agree with Dr. Bailey. More people need to know that this is available. And if they're not being offered a survivorship care plan, they should be talking to their oncologist and asking them to please refer them, or asking them what is the process for that.
Hi, this is Melissa. I actually put the question in and want to ask follow up if that's okay. And I'm sorry, I'm driving, so I can't come on camera. But so I am with the Head and Neck Cancer Alliance, and we are kind of working on what our role is in survivorship care planning, which is why I asked that question. And we are we get a little overwhelmed by what it might look like in terms of providing a survivorship care plan for the whole of head and neck cancer, especially as we are not the ones to implement it. So what I'm kind of hearing from you is really more awareness around, and correct me if I'm wrong, but more awareness of what is a survivorship care plan, how to ask for it and advocate for it, more so than what's on your survivorship care plan.
I think that's right. I think, what is a survivorship care plan? You should ask for one. Once you have one, how do you utilize it? Or what information do you need how is that important to carry with you, to share with your primary care doc, what you need to look for in the future for screenings and risk.
Okay. And then, sorry, go ahead.
Oh, Melissa, I love that you're working with the head and neck population. I love your organization. I point patients there all the time. I have Yes, I have a special heart for the head and neck patients, and we make sure that that every one of them comes into the survivorship clinic. Absolutely. We have a ton of follow-up for them as well, because their disease treatment is very tough and their after effects are very, very difficult.
Yeah, absolutely. Thank you. I really appreciate it.
We appreciate you.
Yeah, I think we're gonna also try to focus more on creating more educational resources. So keep sending them our way.
Betty, I'd love to talk to you about some of that stuff because again, I work very closely or Betty, I'm sorry, Melissa, I would love to talk with you more about that.
Oh yeah, absolutely. I can put my email in the chat in a minute.
Perfect. Thank you.
Thanks.
All right. Next question. Oh, sorry, go ahead.
Oh, Caroline. I'm just putting additional resources for survivorship care plans. I work in the adolescent, young adult, early onset space across the country, and I work with cancer treatment sites almost in every state, and it is shocking to me how many are not producing survivorship care plans on the adult side. I too, I'm in oncology, so I don't have a non-oncology brain, and I can't imagine being treated for cancer and not having documentation of what was done to me. That blows me away. So any of the advocacy groups on here, please emphasize, because cancer is forever in one way or many's, and surviving is insufficient. We need to oh boy, I'm on a roll. I'm sorry, but this is my heart and soul, because so many young people are being diagnosed and the numbers are going up. And they live, 86% give or take live for that 5-year mark. Many of them live for decades. And I know many of them who have been around for decades, and they are losing their hearing. They're having shoulders replaced. They are having heart surgeries. Cancer treatment is rough. It is not as rough as it was. So we're getting better. And we have to treat, right? And we're getting really good at treatment, but it is time we concentrate more of our efforts and our research dollars on surviving. And survivorship care plans are just vital, especially in this day and age when people change jobs and they move, and insurance, the provider in-network list changes year to year. So I hate to say it, but the onus is on the patient to carry that document. I tell young people, walk into every doctor's appointment with that piece of paper or with your phone and say, I was diagnosed with, this is what I was treated with, and this is what I have to do, and this is what you need to know. Because every health encounter, mental or physical, after diagnosis needs to be cancer and cancer treatment informed. I think that's all I got to roll on, but I thank you all, anybody who is in this call right now, because it is imperative that we provide this information to those diagnosed.
Hey, Betty, you're right on. The pediatric oncology world has been steps ahead of the adult world in terms of long-term survivorship guidelines and outcome. But you're right, we have this growing population of adult survivors of pediatric cancer, and we have to address them. They've not had a space before, but we have to address them and give them the tools to continue to go forward. So thank you for bringing that up.
Well, it's not even pediatric. It's 93% of AYAs are on the adult side, and now if we add early onset to that, we're up to around 200,000 people. And the early onset under 50 is the uptick. Although I was listening to an NCCN webinar a couple of weeks ago, 50 to 59 is also starting to go up. It's no surprise. More and more people are going to be diagnosed, and more people are going to survive.
Yeah, and part of actually in the after cancer, we actually have one of our circles is a AYA group, and they're very active and sharing and kind of supporting each other.
Yeah, Betty, I couldn't agree with you more. To have that document actually is it gives our patients an amount of control or power because they know and they can advocate for themselves, because so many times primary care doctors aren't really sure either, exactly where do we go. They're nervous about that. So having our patients having that document could say, here's what they told me, exactly what I need. And then the primary care doctor says, great, let's get those things ordered. And when we have our contact information on there as well, I've had calls from doctors. Is this what you want? Could you clarify this for me? Can you explain this to me? Or I want to do the right thing. You're right. That care plan is its power.
Thanks so much for jumping in, Betty. That was really helpful.
Yes.
I noticed we have a hand up. And I apologize, is it Tambry?
Very close. It's Tamberlane.
Tamberlane.
Thanks so much. And it's very encouraging to hear all the work that's being done. I've been in the advocacy space and the patient education healthcare consulting space for over a dozen years, and I've tracked survivorship care plans very, very closely. At one point was developing one with a health coaching company to try to fill in the gaps of the psychosocial side of things. So I have gone very deep. I also work with a lot of advocacy organizations, particularly in the breast cancer space, but also some in lung. And I think the call to ask advocacy organizations to start education in this or continue if they've already started is an important one. But I also think it's a struggle to if that conversation hasn't happened before in that organization, not everybody has the expertise. And there's an important history to the cancer survivorship care plan. And if we go back and we look at probably the inciting factor around this was lost in transition back in 2006. We are 20 years out, and some progress has been made, but from an advocate standpoint, it's challenging to say that it's been enough. And when we saw on cancer call for cancer care plans back around 2012, 2015, I was watching that very, very closely. 2018, I presented at the Young Survival Coalition annual summit on care plans, 103 patients in the room, 3 had care plans. 1 was a comprehensive plan. The others were just lists of what had been done to them. And so there's definitely a need to continue to close this gap, but also to understand the history, I think, for the advocacy groups to understand the history of this is something that has been worked on for a long time. Efforts have been made, efforts are being made. And so how can we then help spread the word? Because it's really disappointing to know how many patients still don't understand about this. And so I just wanted to, throw in there that there is a long history here, and I think if there's a way to, maybe even create a webinar with resources for advocacy groups to attend, so that they're not starting from ground zero and scratch with everything if they don't have any exposure to this topic, could potentially be a helpful way to get them engaged and be able to more easily provide something, because bandwidth at the nonprofits is tough and budgets are tightening every day.
Yeah, thank you for that. I thank you for being such an advocate too. That's amazing, and we need that.
Thank you.
Yeah.
All right, so our next question is a little bit more practical. So Tanya wants to know and wants to better understand your workflow for identifying the end of initial treatment and how you schedule the survivor visits, who populates the survivorship care plan, and who conducts the visit, where does the survivorship care plan then live in the chart? So kind of getting to the nitty-gritty of that.
For me, we are not right now. We're concentrating on populations of people because, and in every referral we get a survivorship care plan for as well. We need, even in our center, we need more resources so that we can get survivorship care plans to absolutely every patient. So it's difficult. I populate the care plan myself and I sit down with them. The reason I populate it is because I need to know their history as I'm going to go into listening to their story. I have to have that background. And if I have somebody else do the legwork for me, then I don't know the information that I need to know. So, and I do want to say one other thing. This may not completely answer the question, but it's important to realize also that that care plan gives the background and it gives the evidence, but the survivor themselves help with the context. They're going to tell us what they need and what they need to understand. And without me looking at their background, I'm not prepared.
Yeah, so I've seen two models. I've seen one model where the nurse navigators are trying to fill out the plan as the patient goes through treatment. When they get to the end of treatment, they send it to the oncologist or try to get the oncologist to sign off on it so it could be sent. At another place I was, the ACPs or PAs would have a clinic visit with the patient at the end of treatment and fill out the survivorship care plan. But what I also found is they would fill out the survivorship care plan, give that to the patient, and then send them to me in integrative oncology to address all the issues that they had that weren't addressed in that visit. So I've seen two different models for that.
And there's a bit of a follow-up to that, which is what is the timing of giving the survivorship care plan? When is that supposed to come?
I think there's two different ideas. A lot of times I hear oncologists say, it's when we discharge them from the clinic. Yes, that's really an important time, but a lot of the side effects are going to be happening far before that 5-year or 10-year mark. So it's my belief, and from what I've been studying, they should be having survivorship care plans sometime within 6 months to a year after treatment.
Right. If you think about our breast patients, once they're put on the endocrine therapy, that's when more side effects are layered on top of what they might have had through treatment already.
Right. And that's really where the questions begin too, because they aren't in those very supportive settings as often.
What I find is a lot of our patients just put their head down, get through treatment, get to the end of it, and it's like, wow, what just happened? And that's when the questions and the processing, all that happens, that we have to help kind of guide them through that.
100%.
All right, so our next one, and Rick, feel free to come on camera as well, because I know you have a question that was a little bit different, but the question he's dropped in the chat is more important, the question is, more important to add to a survivor's team is a symptom management palliative healthcare practitioner. How do survivorship teams work with palliative services?
A lot of, mostly your larger centers are developing what are called supportive oncology departments, which include palliative, genetics, nutrition, integrative, all the services together. But a lot of the community hospitals don't have that. And you're right. I think it's very important to get your palliative folks on board early for symptom management.
Yeah, I agree with that. We are fortunate to have a palliative care department right within our cancer center. We work very closely with them.
So we address hundreds of people a week through our virtual groups. Majority of prostate cancer, but we also have a pancreas cancer group, a blood cancer group, and others. And we continuously stress, and I would say more so than a survivorship care plan, that they have a palliative care doc on board, because most cancer survivors, I'm a peer. I'm 17 years out from stage 3 prostate cancer. And most survivors continue to experience symptoms after their treatment in one fashion or another. Mm-hmm. And the oncology practices a lot of times just don't have time for them. And the PCPs are a little lost, and sometimes they're out of their depth. Now, when we have, I would guess we probably have about 60 to 70% are at centers of excellence, and about 30% are in community practices. And when they're in community practices, we push them back to their oncologist to set them up with a palliative care with which that practice is associated. And it works. it isn't exactly your survivorship because we know nutrition's another and exercise is another thing, and so we're working all that into the support group. But I'm sort of I'm surprised that we've gone 35 minutes into this webinar and no one else has mentioned um, symptom management or supportive care or whatever you want to call it. The worst thing about palliative care is its name.
Mhm.
That is its biggest burden. We just had somebody this week, a lady with pancreas cancer, and she's finally going to Marfit. We've been pushing her for years. And she didn't want to go near palliative care because of the name.
Right. And you look at some of the studies with lung cancer, those patients had better outcomes the earlier palliative was involved in care.
Absolutely. Yes.
I totally agree with you. And you're right. The biggest obstacle is the name. So there's take some education around that. But and again, with the survivorship appointment, we should be addressing symptoms and if they need palliative care. I agree with you, though. A lot of our patients would be far better off if they had the palliative care appointment early on instead of just getting referred through survivorship.
Thank you.
Yeah.
So next question I think is an interesting one as well. So this comes from Kathy. She said, we're getting stuck on what to do about surveillance after first course of treatment, since most patients tend to have more treatment after.
So I'm not sure I understand the question. Say it again.
So we're getting stuck on what to do about surveillance after the first course of treatment, since then most patients tend to have more treatment.
So surveillance is part of our survivorship care plan, and it's making the nurses confused as to when to provide the survivorship care plan because it includes surveillance, but they're just getting it. We want to integrate it after the first course of treatment, but they're going to get treatment again, and the majority of our patients do. So it's really confusing. It's honestly, the survivorship care plan has put us in a 2-year kind of frustrating situation because it's just, when do you provide it? When is it best to give it? Do you give multiple ones? If you give one, do you include everything that's involved in the template? It's just, and that has been so frustrating to me because my brother, who passed away 2 years ago, we didn't understand what he was going through because he didn't have a comprehensive understanding of what he was going through due to brain cancer and all of the things that changed him because of the treatment. And I just want people to get these care plans so that they understand what happens after treatment and the consequences to the treatment, and how, as a family member, I can help other family members better understand what that is. So any help.
Well, I think that's a great point because, so many times our family members don't know what to do. And they want to be part, they want to help, and they need the guidelines too to what is needed for their family member.
Yeah, and I think that we're moving towards having care plans earlier, like I said, but I understand your confusion with surveillance. Let's say if they're a breast cancer patient and they're going to have ongoing endocrine therapy or whatever, surveillance kind of happens right along with that continued endocrine therapy. They should be coming in and seeing their doctors, and the oncologists are ordering tests. But you're right, it's very confusing. Even the name survivorship care plan is confusing for people because they will ask you, how am I a survivor when I'm still having treatment? So it's a lot of education around that. But I agree with you. It is very important to have it early. The patient needs to know what comes next. And a lot of times, again, we've conditioned them that we lead the conversations. So sometimes when they're in our doctor's appointments, they're listening, but they're not able to articulate what they really want to know. And I agree also that in a lot of times, even after they've seen their oncologist, I agree with Dr. Bailey, then they are sent off to somebody else to manage these side effects because our providers, our oncologists, don't have a ton of time, and maybe they don't even know what the resources are. So it's important for us to know what our resources are, what we can educate on, how we can support.
Yeah, we even
And
struggle with, like I said, I do integrative oncology is when, it's best if I can get involved as treatment starts, but oftentimes the patients are so overwhelmed with that first visit and what's next and the diagnosis and the treatment that
yeah.
we're trying to find the right timing to have that integrative oncology consult, but then get on board the team and help them through. So timing is tough.
Yeah, and I'm sorry about your brother, Kathy. That is really, it's very difficult.
And Kathy, thanks for that question, because I think it was an interesting one to illustrate that question of timing and the complexity that comes with things that aren't so easy and formulaic. So thanks for bringing that up. Dr. Bailey-Dorton, this one's for you from Mary. She said, you mentioned 4 main purposes of a survivorship care plan. One was treatment summary, but what were the other 3? So this is a bit of a quiz for us to remember.
Yeah, so treatment summary and, everybody that was on their oncology team, the treatment team, primary care doctor communication, a summary to the primary care doctor, long-term side effect risk, what they need to watch out for in terms of long-term risk of treatment, and then what their follow-up care and what screening they may need for secondary cancers or just health maintenance. And I think, I think 5th should be integrative oncology, lifestyle, risk modification, all that too. But
Question from Jody, and I see that we have a lot of questions, so hopefully we can in the last minute. So I'll get through as many as I can. And for those of you who we don't get to your questions, we'll try to include those in follow-up that we'll send after. So this is from Jody. Care plan templates tend to be very far above a 4th grade level and difficult for patients to understand. How do you address health literacy when you're creating a survivorship care plan? Great question, Jody.
It's a great question. That's why I believe the survivorship appointment and that conversation is so very important, because when we're going through, I go through the care plan step by step. And because we've had the conversation, because they've told me their story, they're very comfortable asking questions. It gives me the opportunity to educate and to explain more. But you're right. It's a very daunting document for some people. For most people, it is. So I do believe just having that time to go through it and to carefully pause for those questions is helpful.
it's funny when I do a integrative oncology visit, somebody kind of doing the summary and I go through it all. At the end, I'll say, well, what's most important to you, or how can I help you the most? And typically it's not what I thought was the most important issue. It's something that's totally different than that I had my eyes on. So I think it's important to get that patient feedback for where they are and what's important to them.
100%, because it's exactly right. Here we think we know what they might need, and what they're really suffering with is something completely different. That relationship that we've built in that time we've spent with them is so important, so that they can tell us what's going on.
And this is Jody. I'll tag on to that. How do we get the PCPs to actually read them? I mean, we've reached out to PCPs for various reasons. And they say, oh, I got a lot of paper all day. I can't read all that. I mean, what do? They're on Epic. It's right there.
Well, I think it's tough because, like I was in primary care for 15 years and our primary care docs are getting just slaughtered out there right now. And I think, what we've heard earlier was the summary at the top, but I also think giving the patient that summary to help them partner with their primary care doctor about, this is who I am, this is what I've been through, this is where I need to go. Can you help me with this?
Okay.
Yeah, that summary is really important. And I agree with Dr. Bailey 100%. Help the patient to be their own advocate. I also think, a lot of us work in large healthcare systems, and I do as well, but this may sound kind of crazy, but I make as many personal relationships with our outside providers as I can. When I say outside of our oncology clinic, anytime I get an opportunity to make a personal contact, it helps, because then when I pick up the telephone to call them, or something happens, or I send them a Teams message or whatever, they know who they're talking to. It's a good advocacy for our patients. It's not always doable, but
I have this up on my screen just because it was so interesting to me. I had a patient call me and say, my care plan says staging information, endometrial adenocarcinoma, CMS/HCC, staging from corpus uteri, carcinoma, and carcinosarcoma, AJCC, 8th edition. She goes, I didn't know I had that. What is this? I heard I had stage 1 cancer.
Unfortunately, that's not the first time that's happened.
We have to get it down. And I like what you say about talking with the patient, making a summary that you and the patient both understand. Staging information. Stage 1 endometrial cancer. Make it easy.
Yep. 100%. Yes.
Sometimes too, like, I'll have had a patient yesterday, new onset breast cancer patient, had surgery, had positive lymph nodes. It was just the way I explained the positive lymph nodes to her was, hey, the lymph nodes did what they were supposed to do. They caught the cancer. And just watching that perspective change of that patient from what she had understood made a huge difference for her.
I like that. My husband's going through head and neck right now, and I'm going to take that home because he can't understand why all the other lymph in his neck hurts now. He says, "Did it spread?" I'm like, "No, it's doing its thing." But he doesn't trust that. This is how it felt when I got sick the first time.
Right.
And then for Jody and everyone else, Betty did drop in a link for templates for those care plans as well. So if there's something that you want to explore, know that resource is in the chat too. Just a quick note that Anna mentioned important to include the increasing knowledge we have about cardiac risk in those care plans as well. So wanted to include that in the conversation. But then to kind of get to some of our next questions, what is the role of the oncologist after treatment? We've talked a little bit about this. I'm hearing primary care is looked at as the main doctor in the survivor plan. Any thoughts you guys have on who owns that?
That's where a lot of the confusion is. Our primary care docs have often not been involved during the active phase of treatment. Now all of a sudden it's like, okay, it's your responsibility to do all this. And that's not a good communication or a great system. I've seen mostly the oncology most involved in that first couple years. But ideally your primary care docs is the captain of your team and you want them informed of what's going on. But it's just that communication's key.
Interesting note from Kendra I wanted to add as well. So she said, I think there's also a barrier here with mental health. Having the confidence to share and self-advocate is so difficult for many patients. And so, Dr. Bailey-Dorton, your thoughts about helping patients step into that space and have that confidence. Where have you seen that done well?
That's at the end of treatment, that distress, that fear of recurrence that's looming so high for these folks. And like I said, a lot of our patients just put their head down, get through treatment, they keep stuffing all these emotions in, and they get to the end of the treatment, they've got no more room. They need to process through that. And that's where we need to give them that safe space to process through this emotional content of what they've been through and how to go forward with this fear of recurrence.
Yep. And if you open the space for them to talk, they will tell you. And that gives us an opportunity to address it. And even if they don't tell you right out, ask clarifying questions because most of them are dealing with stress about recurrence and other things that have fallen apart in their lives. They lose a lot during treatment. And if we just give them the chance to talk, we'll find it.
And there's often so many times, like I said, we're focused on this treatment side effects, long-term effects, and they're worried about their bills or their transportation or their sick mother or their sick family member. They got so much else going on sometimes that we can't even get to this. And it's a bigger stress for them.
So actually, Jody, I have another question for you that I thought was really interesting. And this would be, I think, for both of our panelists, but maybe others in the room as well. Has anyone held survivorship rounds with all oncology all oncology multidisciplinary team?
We have talked about some of this. We have not implemented it, but wow, wouldn't that be incredible? The one thing we have done is had some doctors come and talk to our group of survivors, but it definitely is something that needs to be thought about.
If you want to talk about Nirvana, it would be Survivorship Tumor Board or Survivorship.
That's exactly what I was thinking. You work on all these accreditations where you have to have all these tumor boards. Well, why not for survivorship?
It'll probably come. That's my guess.
I'll lead it. That's great.
Great suggestion from Gianna here. I like calling it a surveillance care plan instead of a survivorship care plan. What are your all's thoughts on that?
Sounds great. Because like you said, Elle mentioned earlier, the patient's like, well, how do I know? When do I say I'm a survivor? How do I know I'm a survivor? And there's this confusion over that before we even get to the survivorship care plan.
Yeah, I know I've talked to organizations that don't call them survivorship care plans. They call them care plans. especially for our stage 4 patients, that you're giving them a mixed message. And so just calling it straight out, you can call it surveillance, but care plan, I think, is much kinder, or maybe, I don't know, something different, because it is almost heartbreaking when they hear that.
And Rick actually had a thought on the word surveillance. I was going to call you out to see if you were still on, Rick. Otherwise, I'll read your comment.
Yeah, I was going to jump in on this. Surveillance is a double-edged sword. I mean, survivor, I mean, it's not a perfect word, but it has connotations that you've got to do something to stay alive. Surveillance is a problem because it can lull people into a false sense of security, and they don't comply. And we've seen that particularly in the discussions around, should we rename very early breast cancer and very early prostate cancer into something other than cancer. And one of the arguments against not doing it, against doing that and not calling it cancer, is that people won't comply. So I'm just throwing that out for discussion with the term surveillance.
It's a good point.
All right. Next question from the chat is, how does your program manage / update your survivorship care plans to capture all of the new treatments and survivorship guidelines for the primary care physician? Or does your survivorship care plan list clinical trials? Our PCPs find it difficult to stay up to date on all of the changes. We're in the process of updating all of our care plan templates. Thank you very much. So that was from Jenny.
Yeah, that's a hard one. Our survivorship care plans do not have clinical trials, and we rely on the survivorship care plan. A lot of it is populated from the record, and so we do rely on that a great deal. I'm not creating it from scratch. It's pulling from what Epic or what my organization is updating. I'll put it that way.
Can you hear me? Oops, sorry.
Yes.
Yes,
This is Jenny. I'm with the Medical College of Wisconsin in Fredert. And that is something, so our Epic, it does pull a great deal of information in, but it doesn't pull the clinical trials. And so what we're running into is some of our primary care providers are reaching out, and they're just, they can't be experts in all cancers. So some of these new therapies, and even now we have proton therapy, there's a lot of questions. What do we do now? So I think when we're looking at our templates, we're just trying to kind of see if other institutions have ways of keeping these up to date and accurate, or how does their Epic, system grab all this new information? Or we now have bite and till. So it's been a bit of a challenge.
Yeah, it's a challenge too, because Epic is different at each system. So each system has different parts of Epic. So it's not the same universal everywhere.
Yeah, that's right. So it is a challenge. I don't have a great answer for this.
This is Lindsay. I'm one of the Epic analysts at one of the sites. I was just going to say, typically, so it's content that is static. From a build perspective, you work with the SMEs, the stakeholders, that first time, and you pull in what they tell you to pull in. If it is something that, and I mean, obviously cancer is changing all the time, it is something that needs to be more evergreen, you should probably work with your Epic analysts to develop a more consistent cadence to review content. So one thing I know, for example, that we do regularly is update our actual medication protocols, right? Like that changes really constantly. We do have a request process built in for that. I think it's something where it would behoove all of us, including the Epic analysts, right? We want you to have the most up-to-date, valuable content, to have a recurring process to revisit some of these content pieces. Because we can't, if it's in the system, we can probably pull it. We just don't know to until somebody tells us. So, because we're not clinical, I, for example, am not clinical at all. I went to school for Spanish. So, can't help.
Lindsay, you're like an angel that dropped in to answer our epic question. Thank you.
Yeah, 100%. I appreciate that. It's great
Can you
advice.
can you build that box for everybody, Lindsay, at the top of the note?
Well, I did put in the chat. So Epic does have what's called a community library. So like if there's an organization that you trust or like that you've partnered with before, or even if you just want to browse and see what other groups are doing, there's a whole community called the user web where you can connect with other Epic client customers. You do have to create an account. It's free. It's a one-time thing. But then after that, you can actually look at everybody's content. And so you can see, I don't know which organization that person works at that talked about, but if she puts that in the chat, you could look potentially at her smart text that they have in their system today. And the community library, Epic also did sort of a fancy connection thing where, everything is getting dumped into the community library. But if I at Providence wanted some of that, we can actually import parts of it to make it faster to implement. So if there is something you find there that you really love, like work with your analysts. The thing is like, I feel like often with analysts, the IT teams, like it becomes an us versus them because we also have limited time and limited resources, right? So you ask for something, we say we can't do it now. But I mean, like I think it's just making sure you have those relationships and people feel comfortable asking. And like I said, we want you to have the things you need. So don't ever feel bad about asking. The worst they can say is no, not right this second. But getting the conversation started and getting those relationships built is really helpful.
That's great advice, Lindsay. Thank you.
Thank you. Thank you.
So we have about 3 minutes left. We've kind of reached the end of questions in the chat, so I will just leave it to the floor. If anyone wants to come off mute or drop it in the chat as well, any sort of last questions, I think we can probably do one, maybe two more before we close today.
I'll just jump in and say thank you to every one of you that's attended today. I think we all have in our hearts to do the right thing for our survivors, to help them recover, to help them become stronger for what they've been through, to decrease their risk of going through it again. So I thank you all for what you do for cancer survivors everywhere. That's certainly the heart of what we do at the After Cancer. So thank you for being here.
Yeah, and I absolutely second that. You guys are amazing. Keep doing the good work.
And sharing that work with everyone, I think that was a really powerful part of this meeting, was to hear the different voices, the different perspectives in the room. So just appreciate all of you for showing up and for asking the tough questions and getting this discussion going. It was an honor to host all of you.